And then the Achilles, of course, is there. It's also a ligament, right? Everybody knows that, right? Okay, calcaneal ligament. Yeah. What else? Oh, okay. Now, people get confused by this a lot. Think of this, if you're really confused, think of your hand. And the reason, by the way, it is a little screwed up is because your feet in utero are this way. And then as we start maturing and growing as this, little beast, right? This little thing is growing inside mommy, all right? Which is, you're just sucking the life out of her, right? So that's what you're doing. You're nothing but a parasite. You are. So all you got to do, your feet go this way, and then they actually turn. That's why it actually does mimic your hand, but it's just that the feet go and they turn. But anatomically, you're dealt with embryologically. All right? So if I ask the patient actively to take her, could you please get your, take your foot and put it towards your, try to raise it to your head?
Oh, I think, yeah.
No, just like that, okay? What is that? What kind of motion is that? That's dorsiflexion. That's the same as this, okay? Now, could you please take your foot and go down to the floor with it? Plantar flexion. Of course, I'd have them doing both at the same time. Then you could say, all right, what I'd like you to do is to take this side of your foot and just a foot, raise it to that side. Or you can put your hand here. Can you please try to touch my hand, okay? Can you please try to touch your hand, right? I don't want this, I want you to do more of this, okay? Try that again. Good. This way. Good. Same with this. I want you to do this motion. Okay, go ahead. And this. Good. All right? That's inversion and eversion. We did dorsal plantar flexion. Okay, same thing. All right, again, I would put both hands there. Could you please pick your hands up? Your hands up, your feet, right? You're there, please go down. Great. Now, what I'd like you to do is the same thing we did before that. You don't have to do that? Okay, you would do that. I'd also would test for internal and external rotation of the foot. I don't think you have to do that, but I would. All right, what's next?
Anterior dorsal.
All right, so the anterior dorsal, people are like, what are we doing this for again? But it's for the ankle now. Could you please, right now? Okay, you can sit or lay, so I'll lay. Now, what are we testing for with the anterior dorsal? Anterior talofib, the most commonly hurt or commonly stretched ligament, right? So what you want to do, and I'll do both sides. All right, I take I'm right-handed. So I take my left hand, I put it under the calcaneal bone, posterior aspect. I get on to the tibia, all right? So when I have it locked in, what I want to do is I want to see if I can move this. You come down, move it, under here, move it, all right? You want to see what motion it is. Again, you're going to lock it in, you're going to lock it in, right? Yeah, I know, it's just the anterior talofib. But what I do is I always come down and test it. Okay? That's what I do. Whatever you taught, do with the one. I think you want to do it one way. Yeah, I do. I do everything. Because remember, the anterior, think of where the direction of the anterior talofib is. So I like to test it. Yeah, if you can try, it's a little bit harder though. I mean, if the foot's just there, then you kind of got to get down there. This way, she's right there and I can, see? Everybody see that? What I'm in a different position now. I'm here, I'm locking it in, and what I'm trying to do is take the foot and go this way. Everybody see that? Lock. Everybody see that? So I'm causing that difference, and when I'm testing for it, and again, I wouldn't be on this side, but. You okay? Yeah. Okay, crap. All right. But what you're trying to do is this motion again. So just think of the anterior draw sign, right? When we did the knee, I was trying to make it move. So here I'm doing the same thing. I'm coming down. I'm doing that. I'm actually doing this with my hands. Everybody get that? And it's the anterior talofib. What we got next? All right, Thompson. Go prone. All right, so before you guys did, of course, palpate the Achilles tendon. So all Thompson is coming down. Yeah, there you go. Let go. Just relax. You want the feet to be relaxed as much as possible. You don't want them like this, because that will throw you off, right? So the feet are relaxed. You want to come down and just, okay? And of course the test is, if I do this, and the foot doesn't go, the chances are they have a ruptured Achilles tendon. The other thing that might give it away is you're going to see this muscle about this big here, because it all rolls up, okay? That might give it away also. Right?
It's really in pain.
But, yeah, actually you don't have a lot of pain, except when it first happens.
Yeah.
But, yeah, when they come in, you'll see this big ball. Same with the bicep rupture. You see this big ball here. Kind of gives it away. All right? What do we have?
Spine.
Sorry?
Spine.
Oh, okay. Can you stand up, please? You're laying down for that, you okay? Yeah. All right, so for the spine, you should be starting with the C-spine first, right? Okay. So, please face that way. All right, hey, why don't we come down here? Well, I could do even on this level. Kind of looks like. So, the first thing you have to do is what? Inspect, right? So they'd be appropriately ungowned from this area, right? So I'm just looking, and with Ashley right now, she changed it a little bit, but I always do is what I would do is I tell the patient, just stand there and just take a couple steps in space, and then I say, okay, just stop, and just stand there. Now, what happens, because if you say to the person, I'm going to inspect you now, all of a sudden the head goes like this, and everything comes in space, right? So the first thing you inspect. So what do I have here? What's this called? Not, I know it's a cervical. Lordosis. So you have a lordotic curve, kyphotic curve, lordotic curve, and right? That's normal spine. All right? And engineering has shown us that that's the best way for anything to be built that can take compressive forces. Okay? So first thing I'm doing, I look, make sure there's no lesions, ecchymosis, whatever you guys say. All right? Next thing we do is what? All right, so you're going to come around and just palpate. What's the main muscle I'm feeling all through here? Trapezius, right? You have an upper, middle, and lower trap, like a diamond, right? So you're just checking that out and everything. Okay, over here, you can actually get to the rhomboids. Did you guys learn rhomboids? Okay, rhomboids you actually can feel. And then on this area, you have the paraspinal muscle, right? Anything else? And then the spine's processes. All right. So what I do again is I start from right up here by the occiput. Then you have that little indentation, right, which is actually where C1 is. And then I come down, and the first thing I feel is C2, and then I just kind of follow down. Now remember, I can also normally be seeing this, all right, until I get to the sacrum. Okay? Yep. From here, we've already done the sacroiliac, but you can palpate it again if you want. Do you mind if I just see it quickly? No. So after I said it, nobody had it. But you'll see the dimples there, right, for the SI joint. Okay? That's the SI joint. Okay? Yeah, we do range of motion next. Okay? So range of motion, could you turn on, please? For range of motion, I would say, could you, the normal stuff, could you take your chin to your chest, please? Okay, could you look up to the ceiling? And you don't want to hyper extend or hyper flex anything, all right? Then what I do is, when I want to do lateral stuff or rotation, now I take the shoulders, all right? Could you turn to the left, please? And I tap them because, believe it or not, especially women, when you tell them to go to the left, they're like, kind of like where they drive. I'm like, get in! All right? It's very female-centric class. So could you please turn your head to the right? Great. You look straight ahead. Now what I'd like you to do is take this ear and try to touch your shoulder, please. Great. Take this ear, try to touch your shoulder. Great. Okay? Now, if they told you to start off holding the shoulders, even flexion extension, please do it. I don't. Not necessary, but they told you to, please do it. Go
Can we
ahead.
go back to palpation really quick
Yeah.
and like the spinous process?
Yes.
I think I remember Paul mentioning in class like you're supposed to be looking at their face.
Well, I mean, if he's talking about, if he's talking about because you worry about any kind of injuries or infection or anything like that.
I'm just wondering like for the practical, so we get like
I mean, you're going to be really good about this. I would not want to be the patient that has a doctor going like this. Now, I'm not saying that you're not supposed to do it, all right? I ain't doing it, okay? Here's why. If I'm doing this, and if that patient has spinous process, right, where it's sore, they're going to let you know. It'll be like this, you go, oh, they'll feel it, okay, as I go down. Remember, I'm not going lightly. I don't know if you can see this, but I'm not just going lightly. I'm actually, now for the head, for the cervicals, by the way, I usually put my hand on their forehead. And I hold their head while I'm here, okay? Now, as I come down, I didn't put my hand in a check number. I come down from here, once you pass it, I'm going pretty tight. She's like, you go pretty hard. Don't just go, you gotta get in there. If this is something, again, somebody might be